I remember once seeing a woman who had surgery, and I asked her how it went. She said, well, on the way home from the hospital, she stopped at the shopping mall for a couple of hours to pick up a few things. It's at that level of discomfort.
Fellow Homo sapiens, my name is Torie Robinson, and welcome back to Epilepsy Sparks Insights. Now, neurosurgery to treat epilepsy is becoming more and more common, but I'd say one of the fancier, more precise and minimally invasive types of surgery could be laser ablation therapy. In today's episode, we hear all about it, for which type of epilepsies it can be used, crazy short recovery times and more, from global lead epilepsy specialist neurologist Micahel Sperling. Please don't forget to share your thoughts on this episode with us in the comments below, because I really enjoy reading your thoughts on the topics that we talk about and responding to them. Also, do subscribe so that we can educate the masses and empower way more people affected by the epilepsies around the world, and indeed actually more clinicians with patients who have an epilepsy so that they can provide the best care possible.
I'm a professor of neurology at Thomas Jefferson University in Philadelphia in the United States, and I'm the director of the Jefferson Comprehensive Epilepsy Center at the university. And what I do is a mixture of the usual things that people do in academics. I treat a lot of patients, I conduct research, and I am heavily involved in teaching as well, as the three main areas that we speak about in academics. Independently, I'm involved in international organizations in the International League Against Epilepsy, and the American Epilepsy Society, and the American Academy of Neurology. I'm also the editor-in-chief of the journal Epilepsia, which is the journal of the International League Against Epilepsy. I'm a fairly busy fellow because of all that.
We're going to talk together today a bit about laser ablation therapy. It's something I hear about a lot from people around the world, whether it be parents, whether it actually be clinicians, or people with an epilepsy. And it's not something that's available everywhere yet. But I know that you have done heaps and heaps of work on this topic. Could you tell us a bit about that, please?
Laser ablation therapy, which is called laser interstitial thermal ablation, LITT, LIT, is the technical name for it, is a method of treating epilepsy surgically using what we can euphemistically call minimally invasive. So rather than doing an open craniotomy where there's a large incision in the scalp and a piece of the bone is taken off, a piece of brain is taken out, and then everything's closed up again, this is a procedure in which a small probe is inserted into the brain, or two probes are inserted into the brain through a tiny hole that's only 3 millimeters in size. And there's a laser light at the tip of that probe, and when the light is turned on, it heats the brain around it, and actually by heating it a lot, it destroys that little tissue around it. So instead of removing it, it destroys the tissue around it, and a probe goes in and you can ablate the tissue around it. You can plan it very precisely. You can plan exactly the dimensions of what you want to do. You can do one probe or two probes or more than that if you wish. And in that way, it's really a much better tolerated procedure. For example, there's no craniotomy, as I said. There's no big incision, taking a piece of bone off and putting it back, so you avoid a lot of the issue related to a large incision with the risks of infection of a large incision. There's still some risk of infection, but it's much less.
This is rare, but you just made me remember I had CSF fluid leak after my resection. That's something I guess that wouldn't...
Exactly. It wouldn't happen. And to anybody who's been through brain surgery, you're in the hospital for several days at least. It is quite painful. The average person takes 4 to 6 weeks off from work and other activities after surgery, and it hurts quite a lot. This is a procedure where you come into the hospital on one day, you go home the next morning. The pain is minimal. The medication we give for pain is either paracetamol, as you say in England, or acetaminophen in the United States, a few doses. People can go back to work the next day or the day after that.
The next day?
With no limitations. I remember once seeing a woman who had surgery. She was actually in her early 70s. We wouldn't have considered open surgery for her, but this was easy. And I asked her how it went. She said, well, on the way home from the hospital, she stopped at the shopping mall for a couple of hours to pick up a few things.
No.
It's at that level of discomfort.
That's crazy.
It's still possible to have there's still a little risk of skin infection, infection for the wound, but it's really much better tolerated. The efficacy of this, how well does it work? It's probably not quite as good as open resection because you don't take out as much tissue, and in general, the more tissue you take out, the results are a little bit better, but the results are reasonably close. So what's been published thus far is about 60% of patients who have this, for example, for temporal lobe epilepsy, stop having seizures, and most of the remaining people are significantly improved. If you look at published studies for open surgery, it's not terribly different. Maybe it's a few percentage points lower. There's an upcoming study that will be presenting results in December at the American Epilepsy Society meeting. So I can't say those yet, and they're still under analysis, but I think that will come in reasonably close to that. That would be my guess based on what I've seen so far. And again, the advantage of this, again, minimal discomfort. The time out of work is basically the time in the hospital and the day you go home. And then if it doesn't work, you can always go back and do more ablation if you need to, or you can always go back and do an open resection. So if it turns out that operation wasn't ideal for you, you can go back and have something else. And unfortunately, epilepsy surgery, is not 100% guarantee either. So many people still have seizures after surgery. It's a minority, but a significant minority do. And sometimes we have to think about going back as well. So I think that's the big advantage, just minimal discomfort, minimal hospital time, minimal disability, and it works quite well.
Is it good for if people have several different places their seizures originate? So multifocal, could it be useful for that?
I mean, probably not. Generally, when people are multifocal, no surgery is going to work terribly well. I suppose if you have a specific condition like tuberous sclerosis, where you've got several discrete lesions, little tubers in the brain, you can identify seizures come from those three. Yes, this technique would be good for that. But most people who are multifocal have much wider areas of abnormality in the brain, so it might not be suitable. It's certainly one lesion or two lesion, and nothing terribly large also, since the area that you can ablate is not very large. So we look for people who have relatively small, discrete abnormalities in the brain, and you want to target that, and you can do a good job. There's another way of ablating using heat, basically, from an electrode. It's called radio frequency ablation. So the same electrodes that are inserted in the brain to record EEG, you can put current through those and heat the brain there. It's much less accurate, though, in terms of not being able to calculate the precise area that you're going to ablate. The zone of normal versus abnormal with thermal ablation using the laser is very precise. It's very crisp. It's a 1 millimeter area from normal brain to abnormal. When you use radio frequency, it can be up to between 5 and 10 millimeters of brain that's kind of scarred and messy along the way. So potentially causing a greater risk for seizures afterwards as well.
Well, yeah, so perhaps not ideal.
The other thing I would add is that the results that we've seen thus far represent the results since it started, and it's still a relatively new technique. We've been doing it for a little over a dozen years in the States, much less elsewhere in the world, a year or two at most in other parts of the world. And when we see published results, these are people where we started and we didn't really have the best idea of how to optimally target areas. So there have been a number of papers that that have been published, and I've been involved with some of them, looking at the difference between people who stopped having seizures and those who did, and we now know better how to target ablation. So I think the results will be better moving forward than they were in the past.
Okay, cool.
You have to be careful when you read about things. Whenever a technique is new, doctors don't quite know how to use it the best ways. Safety tends to improve with experience, and especially something like this where you have to target specific spots. We learn better how to target, how to design the approach to optimize results, and that I think you'll see, better results today than we would 10 years ago when we were using it.
And is this type of therapy used in adults and children, and like neonates, like babies?
Yes, it can be used to people of any age. The key is to have abnormalities that are not terribly large so that you can ablate them safely. In fact, in children, there's one entity called hypothalamic hamartoma. These are very deep, small hamartomas right above the pituitary gland, and ordinary surgery for that is quite challenging and has a very high complication risk. The thermal ablation is a wonderful way of doing it with much greater safety.
Cool.
Patients who have, again, small abnormalities of development, something called a periventricular nodular heterotopia, so a small abnormal collection of cells deep in the brain next to the ventricles, the fluid-filled spaces. You could target those very nicely with these if they're small, ablate them, and again, it's in and out The procedure doesn't take very long. I mean, you're in the operating room for 4 hours, but the actual light is turned on for 2 or 2.5 minutes. And
Wow.
that's it. And sometimes you may pull it back and then turn it on for another 2 minutes, but it's the actual procedure doesn't take terribly long.
I'd love to watch it. Sounds fascinating.
You can do operations that you couldn't do before.
Excuse my layperson's terms, but you're zapping this tissue that has been identified as being the problem. And what actually happens to it? Because are you like burning this tissue? Do you remove it, or do you just leave it there to kind of like wither away? What happens with it?
Yeah. So this is not like a cutting laser that's used to cut metals, or if you think of some of the old James Bond movie where Bond is lying down and there's a light coming from his toes up towards the center of his body to slice him in half. It's nothing like that. It's a probe that puts heat into the tissue around it, and it gets it quite hot. The tissue is damaged, and then the body's own repair mechanisms basically eat that tissue, and you're left with a little hole where that was.
And that just fills up with fluid and...
Yeah, it's cleaned up by the body's natural mechanisms, and then there's a little hole there, and it scars around it, and that's that. And again, it's quite small. A typical area that's ablated might be 12 to 15 millimeters in diameter. So, half an inch or so, a little over half an inch in diameter.
And so you've already told us about how swift this actual laser ablation can be. What about any potential negative effects in terms of things like to do with psychiatry? Because, we know that that's really common in resections, for instance.
Yeah, so the risks relate in part to the invasiveness of the procedure and how much brain tissue you remove. So this is much less invasive. It has much less stress than an open craniotomy. And the patients don't have to go to the intensive care unit. As I say, they're out in a day from their hospital stay. So the general stress is less, and stress clearly plays a role in psychiatric complications early after surgery. The amount of tissue removed or ablated is much less than in an ordinary resection. So again, the side effects of surgery are going to be less, and the cognitive side effects, again, it depends upon where you're ablating. So the most common place to ablate is the temporal lobe in the deep part called the hippocampus. And you could still have effects on memory there, so there may be some decline in memory after the procedure. You'd have that with resection. But not taking out a lot of tissue laterally on the side, there's less effect on language, for example. If you're ablating in other regions of the brain, it depends what those areas do. And as far as the psychiatric complication, any changes can be followed by a transient psychiatric complication. What we've seen in general with epilepsy surgery, that if there are adverse psychological or psychiatric effects, they tend to occur relatively early, and they typically are better within 1 to 3 months. And on balance, if you look at how people are 6 months to 1 year later, net scales of the psychopathology are much improved on average. It's very easy to make people worse. It's a lot harder to make them better. And it is certainly possible to have a complication with any kind of procedure, as this is. It's still surgery, though. It's far less invasive than an open craniotomy. But we just see less in the way of problems with it.
Thank you so much to Micahel for getting us excited about laser interstitial thermal ablation therapy. It does sound rather swish, honestly, and quite cool. And as with so many other treatments, I'm thinking, gosh, there's an innumerable population of people with a refractory epilepsy who could no doubt benefit from it. Do check out Micahel's papers on the subject. The links are on the website torierobinson.com, where you can also check out the podcast, the video, and the transcription of this episode. And if you haven't already, don't forget to like, comment, and subscribe to our channel. Share this episode with your friends, colleagues, family members, and see you next week.